Good morning, everyone. I think we're going to get started. Thank you for coming. The purpose of this session is to present to you the highlights of a very large report that we have launched a couple of weeks back at the Advanced Breast Cancer Conference in Lisbon. And the way we will do it, together with my dear friend Eric Weiner, that will chair the session, I will briefly present part of the report or the highlights, and then we'll have a panel discussion, and we'll do that twice, touching different topics. And of course, the purpose is to be as interactive as possible. I don't know if you want to say a few words.
No, I'm just very happy to be here, and I actually want to congratulate Fatima on the incredible work she's done through ABC, and a meeting that, and I've said this publicly before, so I'll say it again, the first few times that ABC met, I thought to myself, where's this going? And it has gone to a very great place, and it is one of the few meetings that really is able to effectively bring together researchers and clinicians and patients and advocates in a way that's just enormously productive. And I think the report that you're going to talk about was very helpful, and I look forward to discussing this morning.
Okay, so let's go. Let me go back. So this first discussion, we will focus on the goals that looked into what happened in survival, and also in quality of life and data collection for metastatic breast cancer. So these are my disclosures. I believe that everybody is aware of the Advanced Breast Cancer Global Alliance, but for those who are not so familiar, we are like a federation because our members are organizations as well, not individuals, all around the world. And we are now over 300 members in over 122 countries. And the idea is to share and to collaborate so that everybody has a fair chance and recovers the accessibility and other gaps that are still existing around the world and in each individual country. So many years ago, we created the Alliance in 2016. And at that time, we had done a report looking into the decade of 2005, 2015, and what had happened in the field of metastatic breast cancer. And what we saw is that the advances were really, really very slow and very small. And that was the basis for our ABC Global Charter that we define all together, patients, researchers, pharma, everybody involved. And that led to 10 goals for which we have fought for during this last decade. And the decade has come to an end. It was 2015 to 25. So now we have looked back and see what happened in the field of metastatic breast cancer in this last decade. And this is what we will be discussing today. So the purpose is not to talk too much, so I'll go very, very briefly on the highlights, and then I'll give you the references so that you can have access to the full report. And you also have copies of the full report and of the breast journal that has a summary, an executive summary of the report, and you have it outside on the table, so please take one. So what we have seen in terms of achievements, but also what is missing, the gaps. Let's start with goal number one, that was improve survival. So what we have seen, when we look overall, all breast cancer subtypes together, percentage of people that are alive at 5 years went from 26 to 33%. Still very slow and still very little, but consider that last decade, it went from 24 to 26. So there was at least an improvement this last decade. And we now know that for 2 of the subtypes, we can have a median survival of over 5 years if there is access to the targeted agents. And we, at the beginning when we started, there was almost no high-quality guidelines for the management of metastatic breast cancer. And now we do have, and the majority of societies have, and also many countries have developed national guidelines to treat this disease. However, what we have also seen is that the impact in survival has not been the same for all the subtypes. And if for triple-negative breast cancer, we still have a median survival of about 1 year. So there's a lot of work to be done. And what we see is also, what we see in clinical trials, we don't always see in clinical practice. So there is this gap of what happens in clinical trials and what really happens in real life. And of course, this improvement is linked to accessibility, and I'll come back to that. So this is a graphic that we had presented 10 years ago. I'm not sure I can point. Oh, see, yes. So focus on this one here, which is stage 4 breast cancer. So this was the initial decade, 23%, 26%, and now 33% in terms of percentage alive at 5 years. So things are improving, still very slowly. There's work to be done, but things are improving. At the ABC8, we also had a real-world data study presented based on the Flatiron database here in the US. So this, for those of you who live in the US, this is real-world data from the US. And what you see is the evolution since many years back, so 2011 until 2022. And this is the triple negative. So as you can see, we have not made a huge advance here, but for the other subtypes, the HER2 positive and the ER positive, we see a substantial improvement. And so there is room still to do more, but we have seen, at least for a large percentage of metastatic breast cancer patients in real life, an improvement. Now, goal number 2 dealt with data collection, and many of you know that if I ask you how many people are living with metastatic breast cancer in the US, you don't know, right? And we also don't know in Portugal, and we don't know in the UK, and we don't know in almost every country around the world. So, but we have made some progress, perhaps not as much as I had hoped when we started this fight, but at least we now have standards on how to collect the data. This is something good because everyone should collect the same way so that we can then add and have global statistics. There is, of course, the introduction of AI models and data linkage models that hopefully will help us collect data from real world and have real numbers of people who are living with the disease, not just estimates. And we have had in many countries registries that have focused specifically on metastatic breast cancer. So we do have data for some individual countries. However, we still don't know overall how many are living. And we speak about a lot of things, and in this conference you will hear people speak about progression, line of treatment, but sometimes what people mean are different from person to person, and we need more standardization on what we are talking about. So a couple of additional pieces of data. I think one very easy piece of information we should have from all countries who have a cancer registry is staged diagnosis. So if you have that, at least you know everyone who is diagnosed as stage 4. But if you look here, you will see and I'll point out for the US, less than 20% the report of staged diagnosis. So it is the US. I was expecting a little bit higher percentage than in other countries where they struggle with the cancer registries. And these are examples of national initiatives. Some of them have already provided very, very important information, like the French National Registry, ESME. We have learned a lot about metastatic breast cancer coming from real-world patients. But we need this to be done within the cancer registries, the official cancer registries of each country. And I don't have the time to go into the details, but maybe in the discussion we can speak about the effort just done in Australia and Northern Ireland. These are the first countries that have a number of how many people are living with metastatic breast cancer. And for example, for Australia, the number is more or less the double of the estimate. So what means is that everything that you have seen about estimations of number of people living with the disease is really underestimating how many people are living with this disease. In Australia, it's the double. So imagine how many people are living here in the US, because the estimates point to 150,000. It's probably the double of that. Now, what about quality of life? So we talk about it very, very often these days. I think it's almost impossible to go to a conference that you don't see quality of life discussed. This was not the case 10, 15 years ago. And we have seen, particularly in breast cancer and in ER-positive breast cancer, delay of use of chemotherapy. And hopefully that has also had an impact on quality of life. But we are still measuring quality of life in the metastatic setting with tools developed for the early setting. And so we are not capturing a lot of the differences. And I think you saw, and you will see it again in this conference, usually the conclusion of a quality of life analysis of a trial is there was no difference between the two arms. And we know from the clinical practice that it's not exactly that way. But advances have been made, and a lot of us are trying to implement patient-reported outcomes collection, both in trials and in real life. However, what is still gapping, you see there about 80% of metastatic patients report a negative impact of the disease on their emotional and psychological health. We are in clinical practice less than 50%, so about 45% of physicians are assessing quality of life regularly, and even less are doing it with standardized tools. And we tend to forget the grade 1 and 2 side effects. We just focus on grade 3 and 4, and we forget that if you have a grade 2 persistent side effect, that has a huge impact on the quality of life as well. So this is using a non-cancer specific tool, but it allows us to show that throughout the decade, overall, there has been an improvement in quality of life. The previous decade, this was not seen. There had not been an improvement in quality of life. But when we look at aspects of daily living, you still see that the majority of people have a negative impact. It's the green color. So in the different aspects of the daily living, there is a negative impact of the disease, perhaps with the exception of relationships. And maybe, Eric, we can discuss this with the panel. Why is it that somehow the disease is improving relationships? So that will be interesting. And then access to care, which is the last point for this panel discussion. This is the goal where, unfortunately, if I can say, we went backwards. We have a bigger inequality. We have bigger inequalities around the world and within each country as well. So this has increased. We have inequalities in accessibility of high, expensive drugs, but not only. We also don't have a proper access to inexpensive essential medicines. And we tend to think that this is only for low middle-income countries. But I'll let you know that I come from a high-income country, a small but high-income country called Portugal, and we didn't have tamoxifen for over 6 months in the previous 2 years. So if I don't have tamoxifen, how am I going to treat the premenopausal women? So I'm going to treat the young women with breast cancer, right? And there has been quite a lot of efforts. There are some efforts described there to improve this accessibility, including also access to radiation. But as I said, access is very different within each country and between countries. And it's not just access to treatment, it's also access to diagnosis. There is a huge increase in the costs globally, but also on the out-of-pocket costs. So patients are paying more and more in the different countries. Here, again, the data for the US, these are the costs of advanced breast cancer from 2015 and projected until 2030. But if you look, it's not just the direct costs, the costs of treatment, it's also the indirect costs, the costs of loss of productivity, early death, and all the impact that that has on the society. And then for out-of-pocket, you see this is how it is increasing and how much US patients have to pay out of their own pocket. And this is the same all over the world. Even in countries with a national health system, the out-of-pocket expenses are increasing. And this is just to remind us that it's not just the expensive drugs. It's also radiation, pain medication that we will discuss in the second panel, and also essential medicines. And this is what you see there is availability of what should be available everywhere. This is in the WHO essential list. And what you see is that the darker is the low middle income countries, and then the lighter green is the high income countries. And you see that drugs like trastuzumab are almost not available. And also drugs like we use all the time, chemotherapy drugs, are also not available in many of the countries. And it's not just treatment. So this is participation in clinical trials. We had a session last year here with the US MBC Alliance. And in the US, it's about 7%, the percentage of metastatic patients that go into trials. And you see there the different countries, it's more or less the same. Most of them have not even been invited to participate in a clinical trial. And finally, access to multidisciplinary care. We are talking about it, and we are talking that patients with metastatic disease should also be discussed in tumor boards, which we didn't do 10 or 15 years ago, but it's still very unequal. It is very different from center to center, from big centers to more regional centers in big cities or cities that are further away. And there is no routine assessment if we are deciding better when we do it in a tumor board. So a lot of food for thought, and I would ask Eric to call on the panel so that we can have some discussion. Thank you.
Thanks, Fatima. That was a great start. And if we can have the panel members, Mariana Chavez-McGregor, Joseph Gligarov, Frederic Pinal-Lorca, Ginny Mason, and of course, Fatima's here. All right. So this discussion is on improved survival and quality of life for some or for all, the widening gap of inequality. And of course, Fatima, when you present those survival statistics of 5-year survival of 33%, that's not true for everybody. And so, for those who have resources and support and on, it's probably better than 33%, which means that for others, it's significantly worse. And we see this across all aspects of healthcare and medical care. We see it in early stage breast cancer, and we certainly see it very much in advanced breast cancer. And maybe I'm just going to open this up and get people's thoughts on both the magnitude of the problem and what we can begin to do to combat the problem, because it's significant. And I'm going to call on Mariana first because she's sitting next to me.
Good morning, everybody. Thank you, Fatima, for allowing me the opportunity to be here. I think this is a topic that it's very passionate from the patient and patient advocacy perspective and as physicians. And I think there's, different ways to tackle that. Of course, we need to understand that in terms of outcomes, not all breast cancers are the same. So there's that heterogeneity in how we've made great progress in certain subtypes of breast cancer compared to others. But then there's our patients getting access to those improved therapeutics. So then it somehow becomes an issue of having access or not having access to that. We tend to think about countries like the United States, where we have a lot of drugs and resources, but also within the United States, the care that patients receive, it's very heterogeneous. In the United States, we know very clearly that there are very important disparities based on race and ethnicity, with Black patients being 40% more likely to die of breast cancer. Just think about it, right? 40% higher risk of dying just because of, patient, it's Black compared to their white counterparts. But then the reason I think, to really dig, and maybe we can start with that and I stop my contributions, is what is that as the meaning, right? What is it? And I think it's not only biological differences. I think it's who are these patients, right? Racial and ethnic minorities are more likely to live in rural areas, to not have health insurance, to be under the poverty level, to not have education. So it's what is this a sign of? And I think ultimately the goal for all of us to potentially think about solutions is how we get these extraordinary advances to be for all our patients, right? We're going to hear about extraordinary things the next couple of days here, but that it's not really automatically reaching everybody.
Yeah, no, I think that's all very important points, and we're going to go down the panel, but I just want to actually add one thought, which is that oftentimes people talk about access to care and think that access to care is the whole problem, but it's only one piece of the problem. Because, of course, if you can access care, but you can't communicate with your healthcare providers, or you have access, but you can't manage to get there because you don't have enough money to pay for the transportation. These are all huge issues. All right, why don't we just go down the row here?
I'm going to talk about also the diagnosis and the biology of those cancers, because at metastatic stage we know that we can have some changes. So I think it's important when we are able to reassess the disease and the stage of the disease, and we know that it's not always possible to have access to this kind of things in many countries. It's also expensive to get a biopsy, but we can do plenty of things with just a cytology for the patient, but at least to reassess the different parameters. And also now, if the drugs are available in the country, we know that we have also some simple molecular biomarkers that also can give access to treatment. So it's also very important to be able to have access to this kind of evaluation for your disease. I would like to go back to the access to treatment. There is also something that when you have a diagnosis of metastatic breast cancer, it's also a terrible news, and some patients just don't think that it's the end of it. And if it's too complicated because you have to travel to somewhere you don't have access, or you don't have a good insurance in some countries, you will just don't go to your doctor, or just have a first appointment and don't go further because you think that it's just a mountain that is too high to climb for you because you are sick and you have to gather money, you have to have people helping you, and you just don't go. And I think this is something that we really need to change also for the patients.
Jenny?
I guess I would speak more to the patient edge, since I'm the patient rep here. What I'm seeing, at least in the United States, sadly, is access to even living near a place you can get treatment I live in a rural community, and we don't even have an oncology person at our local hospital. Someone comes once a month. And so the nurses are taking care of patients, and people question why I still drive 600 miles to see my oncologist once a year. Because I don't trust a general oncologist to have enough information about a disease like inflammatory breast cancer that I have. And 30% of the IBC patients we have are metastatic at diagnosis. And helping people find the kind of care they need and finding out what kind of coverage do they have to be able to see someone, and as you mentioned, Eric, paying to go to a major medical center, just parking can be prohibitive for someone, and taking off a whole day from work. And I think there's so many other pieces that we forget about when we focus on just the medication or those kinds of access. For someone to have to miss a full day of work, pay for a babysitter, pay for parking and so forth, that probably limits who can be in a clinical trial too. All of those kinds of things. It's not just one issue, it's so many different things, and we have to take those into consideration. Like you said, when we hear all these great things at this meeting, we all go home, we want to see everybody have access to these things, and it just doesn't work that way. Sadly, people will read the newspaper and say, why is that not ready for me next week when I see my doctor?
Whoops, thanks. So,
And Joseph, maybe I can ask you to give sort of more of a European perspective on this, or something. Mariano talked about the U.S., and if you could, in addition to anything else you were going to say, comment on how you feel things have evolved elsewhere.
okay, so we have several challenges in Europe. First of all, even if we have the approval of the drug at the European level, the reimbursement is not equal in each country. This is the first thing. So you might have an approval for all Europe, and some drugs might be totally, I would say, reimbursed in some country and not reimbursed in another one. The second point is that the healthcare system are not equal regarding out of the reimbursement, some possibility that you have of covering the travel to go to see your oncologist or these kind of things. Then the accessibility to, let's say, high-level comprehensive cancer center is not exactly the same in all the countries, particularly when you look at the eastern part of European countries. And this makes the situation complex. You could not have a total, I would say, picture of Europe saying that in all the countries it's the same thing. It's totally different. And even the level of, I will not say knowledge, but I will say education, particularly not only in oncology, but in the field of breast cancer and more in the field of metastatic breast cancers, is quite different from one country to another one. So this makes the situation complex, and for the patient, we have regularly, even out of the European region, I think about some of our colleagues that are living in North Africa or in Africa or in the Middle East, coming in Europe to just have some help to understand what is the optimal strategy to treat the breast cancer they have, even in the metastatic setting. And in this point, it's very complicated to give some, I would say, clear recommendation, because on the other part, if the majority of the drug you recommend are out of pocket, then you have to think a lot if this will really change the life of the person you have in front of you regarding the overall survival expectancy, or it will just put the patient in a crazy situation when she will want to just have this drug, but for a few months of improved overall survival. So the situation is, I would say, really complex in Europe when you look at all these things. But one of the point, as Fatima mentioned about the enrollment in clinical trials, and I think that we have, what is the paradox that we have actually, it's we have never have so much drugs under development in breast cancer, with a lot of hope regarding the different drugs we have, targeting not only in HER2 positive and hormone receptor positive, but even in triple negative, some particular subtypes that might be very helpful in the future. One of the problems I see, and not only maybe in Europe and US, is that we have less and less, I will say, classical academical trial, trying to understand what is the optimal strategy we have to apply using these drugs. That doesn't mean that we could not work with the pharma company. Of course, we need to work with them. But we need also to have access to a lot of data that sometimes we do not have access to, understood what is a subgroup of patients that clearly benefit from one drug to another one, and build strategy that will help the other one. So improving the enrollment and facilitate the enrollment in clinical trial, but also building academical clinical trial with, I will say, high level of expertise regarding the data you will collect, and also how you will interpret this and build the global strategy of treating breast cancer is probably one of the key, I will say, for the future to try to improve the overall survival.
I can add something. In Europe, and I think maybe it's the same in other parts of the world, but it's extremely difficult to get funds for de-escalation trials. It's only through national grants, academic grants, and it's very expensive. We need a lot of patients to be enrolled in the trial, but those trials are so important to diminish the side effects, to give the right drug for a long time, for a shorter time, or for a better administration. And this is a problem. We have a lot of trials evaluating drugs, but not comparing always all the subtypes or subgroups. But de-escalation trial, it's extremely difficult to fund.
I think that's true around the world, given the fact that the funding largely comes from giving agents, not taking them away. Fatima, comments?
Sure. I also don't want to take, if somebody wants to intervene, please come to the microphone, because that would be, the goal is to be interactive. I don't want to speak too much, so please.
My name is Sheila Gaudreau. I am an embassy patient de novo, a little bit over 10 and a half years living with the disease. I'm very encouraged with all the advances. I attended ABC 8, and I'm thrilled with what I see, and I love the goals. I think where I struggle is, in order for us, I mean, we could have access to care, we could have the information and the ability for that doctor or medical professionals to talk to the patients, but it also requires a change in the mindset of the patient. You're not being there to be told what to do. Unfortunately, on top of everything else you're enduring, you need to take on the responsibility and shift to be, one, I need to know what this is. I need to understand what options are available based on the basics of my disease. And then I also need to have a willing healthcare professional that understands that at the end of the day, it's my call, and it's a conversation, not a monologue. I'm not sure I've heard much about how do you switch the mindset so that the patient from the beginning understands you have to do a little bit more than what you normally do when you go to a patient medical professional consult. Again, I'm in the US, but is there anything either in the US that may be helping change that, or maybe things that you've observed in other countries to kind of help get that patient voice mindset change?
So
Maybe I can start. I totally agree with you. I think the ideal model, it's a partnership, right? Particularly, in this long relationships that we want to have with our patients, we can, be with you in a very long journey. I think the key is the partnership, when we can really, understand the goals of care and the priorities of our patients. And I'm thinking, maybe I'm just being too optimistic, but I really think that things are changing. And maybe it's coming from, more empowerment from our patients, the great work that you guys have done in the advocacy community, spread of information, that it's really empowering patients through joining support groups, et cetera, et cetera. Tomorrow we're going to have a session, I believe it's right here at 12:30, where we're going to talk about how, get patients, more involved. I think then your voice in the communities about, this engagement and partnerships, it's incredibly helpful. I think it's very different sometimes in other countries where culturally there's a much more paternalistic type of patient-doctor relationship. But I think things are changing. I don't know, how you all think.
Oh, go ahead, Joseph.
No, just a comment. Thank you for the question. Just to let you know, there are several, I would say, initiatives in different countries. In my university, we have built close to 10 years now a university patient, a patient university, when we try to help the patient that are still on treatment or those that have been treated, how to address the questions, how to help the patient to better interact with the doctors. Because there are two things. One, of course, is to help the doctor to understand what the patient wants and to try to optimize the exchanges you have. But you also need to formalize exactly as a patient, what are your expectations? So this is one thing, and we actually, some of these patients that have received diploma for helping other patients. And the other initiative we have still last year, when we are beginning to build, is a patient research group, trying them to address what are the key questions regarding the clinical research. Because one thing is what we want, as I will say, oncologists, looking, of course, at the endpoint of overall survival and quality of life, but there are some things that we don't have the perception, to be honest, because we are not living exactly with the disease. And we need this expertise of the patient to try to help us to better, let's say, have a design of the trial, the endpoint, what is crucial for them or not. And this is a group that we want to push now in my university to try to help how to build the future of the clinical trials.
We're gonna take one more question, and then we're gonna have to switch the panel. But I just want to make one comment very quickly, which is that I think that doctors and nurses and advanced practice nurses need to be very open to shared decision-making and really do need to view this as a partnership. I have a but, though, and the but is that I think we can't expect too much out of the people who are our patients. I mean, I'm thrilled when somebody wants to take part, but not everybody feels empowered, and we can encourage it, but I don't think we can expect everyone to be the same as the advocates in this room, who by definition are a different breed. And I just think we have to remember that all sorts of people come to see us, some of whom are ready to participate in decisions, and some of whom we can encourage to participate, but are just not quite there yet. Next question.
Good. Hello, thank you. I
Hi.
hope I can keep it to one question. Just a little background.
I'll do my best to keep you.
I'm a medical advocate, and I have worked with a group called Cancer Choices, and in that I have been connected to patients in Singapore, in South Africa, in Mexico, and it's clear to me that when they reach out and they're reaching out and they find me in the United States, it's like, wow, what happened? Where's your resources in your country, right? So, and I'm glad someone mentioned the cultural issues involved here, because, you know, with metastatic breast cancer, it's known as uncurable. So people know they're going to die. And a lot of times, at least in my culture, which is Mexican, we weigh our decisions in terms of the personal impact to the family impact and the financial toxicity that you guys have all been talking about. I mean, I know people that choose to die rather than to, and I think that needs to be a decision to be honored in some way. I don't know how we honor that decision, and we'll talk about it. So, okay, so that's my background. And my question is, how come the drug companies aren't more involved in providing compassionate care resources for the people that need treatment that you know would benefit them in the metastatic breast cancer that isn't paid for by their socialized insurance? I tried to get this for a patient in Mexico, and I mean, it was something totally standard of care in the United States, right? But I could not get the drug company to do it. Why is that? why is that not happening?
That's for you.
That's for me? I don't know. Oh my God. I think it's a question without an answer. It's one of these things that I wish we all had answers to. I think we all have to recognize the fact, and I suspect there is no one representing the pharmaceutical industry in the room. Is anyone here? They're afraid I'm going to call on them. But I think that I think we have to recognize that while there are wonderful people working at pharmaceutical companies, absolutely wonderful people, but if you work for a pharmaceutical company, your job is to make money for the shareholders. And so I think there are companies that do provide drugs on a compassionate use basis, but the problem is that the demand is huge. And there is only so much that they're going to be willing to do. And ultimately, this is about advocating for social change and for changes in the way we provide health care both in the U.S., which by no means is a perfect system, and around the world. And, it's very, very painful that we have all of these wonderful, expensive drugs that unfortunately are only available to a limited population.
And Eric, maybe I'm going to just answer to that on one thing. I don't think it is up to the pharma industry to do that. I think the whole system needs to change. The whole funding system of both clinical trials, drug development, and then drug pricing. Because also, we say that, but pharma is business. But what about our taxes, our money that goes to the governments? The governments all over the world, they do not invest in drug development. They don't. Do you know of any government who is actually developing new treatments? They are not. And so at least there has to change the system and make sure that the price of clinical trials is going down instead of going up, and it's going up all the time, so that the drug can be less expensive when it's finalized. I think the whole system, we need to change the whole system. It's not good to point fingers just to the pharma industry, because they do their part. And I know that they could be more flexible, I know that. But, and I'm not gonna look into Maura because she's there alone and we don't wanna crucify her.
Are you a pharma person?
Yes.
Oh, did I say anything that offended you? No. I mean, no, I think Fatima is exactly right. And I think it's.
And I don't wanna be rude, but I'm gonna kick out this panel and ask for the next one. And
should we have the next panel come up?
yeah, they can already come up, and I'll do the introduction very, very quickly.
You
and
want to do it without slides?
And Rancy, you will ask your question afterwards. I'm going to advance the slides very quickly while the panel comes up. So the second panel would be to discuss caring for the patient, not just treating the disease. And you already asked a question about communication and shared decision-making, and what we have seen in the report is that we have evolved the training of both physicians and nurses. Now it's in the curriculum of medical oncology, at least, that you need to be trained on how to do this. However, 80%, when we ask the physicians and when we ask the healthcare providers and the patients, 80% of the healthcare providers say that they do shared decision-making, but only 30% of patients actually said that they had a shared decision-making. So there is a disconnect, a reality that is not really perceived the same way. And only about 46% of patients said that they feel that their doctors always address their emotional and psychological needs. I'm going to go and skip this so that we have more room for discussion. This was a very interesting piece of data that you can find in the report, is how do we rank the factors that help us take a decision according to the patients and according to the healthcare providers. And there are differences on the factors that we use to make the decision. Regarding information, there has been, fortunately, in this last decade, a really important growth on information dedicated to metastatic disease. Now it's very different than 10, 15 years ago. The availability of information is there. Is the information reaching the individual patient? That's another question, right? Or is only reaching a piece of or a portion of the patients? There are also advocacy groups, so many of you are here representing, but 10, 15 years ago, there was almost no group dedicated to metastatic breast cancer, but now things have really evolved. However, when we see about the information that exists, it's almost always around what is breast cancer, what are the right treatments, but what about the other needs of the patient? So for example, employment, financial support, psychological care. There are much less sources of information for that. And almost everything now is digital. But don't forget that not everybody can reach the digital sources of information. So again, this is just showing the increase of the available information and the topics. As you see, everything that is more scientific has a lot of information. Everything that is the rest of the support of the person, we have much less information available. And regarding availability of support services, and what we call support services is everything from psychological support, social, financial support, diet, exercise, everything that helps you as a person, and also palliative care. So we now have palliative care in many of the national cancer control plans. We have seen an improvement in psychological support, but when we look at what happens in real world, about 55% have never been offered these support services, never even been offered. We're not even talking about the funding. Many of these services are out of pocket. They are not covered either by the national health system or the health insurance. And we still, and I think Miriam will then discuss, but palliative care is still introduced very, very late in the course of the disease. I just chosen to show you this figure that is factors that interfere with your access to palliative and supportive care treatment. When we call supportive care is, for example, control of nausea and vomiting, so control of symptoms. And you see that if you're treated in a hospital with an oncology department or without, like Jeannie said, if you have an oncologist or not, your access to these treatments is very different. If, for example, in Europe, if you live in Western or Eastern, you have a huge difference. And look at the difference between low-middle-income countries and high-income countries. And these are inexpensive treatments: pain medication, nausea, vomiting medication, diarrhea medication, and these are huge differences. And here, the figure relates to palliative care, and the light blue are the percentage of patients who were never offered and never used palliative care. So look at I don't remember who mentioned, but for a mostly incurable disease, look at the percentage that never had access to palliative care. Finally, stigma and isolation. We have moved forward in this last decade. We talk more about it. It's not so much a taboo, but we still have a lot of misconceptions. About 50% of patients still feel isolated. I'd remind you that I started this effort in the early 2000s because of a survey that showed that about 70% of metastatic breast cancer patients felt isolated, alone, totally alone in their fight. But it's still 47% that feel misunderstood or isolated. And there's still about 1 out of 4 people that think that treating advanced breast cancer is pointless because it's incurable anyway. So 1 out of 4 is still a lot of people. people. So I'm going to skip this because of time. And I wanted to show you that not everything is dark and sad. And when we do social listening, and you see the emotions associated with advanced breast cancer, I was very surprised. You see, of course, sadness and fear, but look at the percentage of joy. So it's quite an interesting thing for us to discuss. Maybe I will ask Eva to make some comments. Maybe it's just because it's social media. Social media is a bit different place. And finally, the legal rights, including the right to work. We're talking, I don't know here in the US if you're talking a lot about this. In Europe, we've been talking a lot about adapting the workplace against discrimination, but we're still not there. And 70% of patients report a negative impact on their ability to continue to work. Things are not implemented because the laws, even if they say that you have the right to have certain to keep your work and to continue to work, they say that it depends on your employer. And if it depends on your employer and it's not verified, it won't happen. And also the support for caregivers that is lacking. So the panel is already here. I'm going to excuse just Cynthia because her plane was canceled due to the snow and she was not able to come. And leave you with the new charter, the new 10 goals, and ask now the panel to comment on these topics. Thank you.
So we have a great panel, Belinda Keeley and Miriam Lusberg and Eva Schumacher. I'm going to apologize that I actually have to leave for another commitment, but and I know Fatima doesn't want to be the moderator, so I'm going to ask my colleague Miriam Lusberg to moderate. She's a little surprised, but that's okay. And I'm going to leave you with one comment, which is that I often say to patients, if all we did was dispense chemotherapy or whatever therapy we're giving, it would be a pretty boring job. And what is really satisfying from the standpoint of being a medical oncologist or any breast cancer professional is getting to know a patient and working with them and not just treating the disease, but treating the patient. And I suspect that that sense is something that everyone can relate to. And so I will leave you with that thought. And Miriam, I'm turning this over to you.
Great. Thank you,
And
Eric.
he didn't say he was going to do this.
It's okay. It's okay. We'll wing it, and the panel will help me. So, really important data from the ABC Global Charter. Thank you so much, Fatma, for all that you're doing. So, would love to kind of start with initial impressions from Eva in terms of what stands out for you, kind of seeing these data in terms of access to these support services, gaps. What jumps out at you as a longstanding patient advocate?
Thank you, Mariam. Well, I think first of all we have to clear the wording, because I think that in some countries supportive care and palliative care means the same, in other countries not. So all the number statistics saying I had access to supportive care, I'm a bit cautious because many patients are not aware that even supportive care in terms of nausea is supportive care or palliative care. So I think we have to be a bit cautious. But what I see is that, I mean, years ago, we didn't have a choice as metastatic patients. We had one therapy and we had to take it or leave it. But now, since in most, or actually in the meantime, in all cancer therapies, we have options, which is something really great to have. We start asking about adverse events and about supportive care. And I realized that a lot of is happening in the field, especially, for example, MASK. And Mariam, you can say more about it. They are including patients and communicate a lot about supportive care. And my impression is that a lot of oncologists, and sorry, I'm sure all of them sitting here are different, but they're not so good in supportive care and dealing with adverse events. It's usually nurses, but they don't have so much power in clinics, but I think that this whole field is evolving a lot, and patients should and have to demand much more. Whereas I want to mention to the point before that patients have to be active. Yes, but not all of patients can be active. So we also have to make sure that those who are not able, for whatever reasons, to be active patients, that they also been taken care of. And to Fatima's question about joy, I think, yes, it's social media, so most of the so-called influencers that have a lot of outreach but no content, they of course want to show themselves as, yay, this is kind of party, and I go like, okay. In the closed groups, you rather see also sadness, but on the other hand, we also know that the good periods of life when a treatment is working, we are something like happiness that that is extreme. So it's like a roller coaster with extreme ups and extreme downs. And I think the percentage was around the same between joy and sadness. And I think that reflects quite good the roller coaster we are in.
Yes, that's very true. Thank you, Eva. I think the misinformation and stigma piece was really important. I think we are in this age where some patients are getting some of their information from social media, and I think in many circles, some of the standard of care options in oncology are currently under attack, and some unsubstantiated claims are being made. So I think this is part of the work that we as a community need to come together and really address some of the myths. We, in the United States particularly, we have patients seeking going to different regions or different regions of the world and accessing treatments that may not have been shown to be as beneficial. So there is definitely some of that happening in the metastatic breast cancer community in the U.S., and this is something that does need to be talked about. Belinda, your thoughts on some of the data that you saw?
Yeah, thank you. So I'm from Australia. So as we were mentioning earlier, Australia is now able to count our number of people living with metastatic breast cancer, and we have found that it's double what was initially estimated. So I think we've really made great advances in that case. However, we still are lacking in a lot of the things we've just talked about. I think that one of the things I see is the support services. So Australia is a wealthy country, and yet really access to the support services seems to be limited to people with the money to pay for it. I think that unfortunately support services are still seen as a luxury item, as an optional extra that people can have if they can pay. I just think we have such resourcing and workforce shortages to actually provide good support services for all our patients. It's a real challenge. I think that we recognise that support services should be essential, not a luxury. But how do we make that happen? And I think we maybe need to think of more innovative ways of delivering support services in this context of financial shortages, workforce shortages. And so should we be looking for web-based models or telehealth models or some other way of trying to get more access to the support services for all our patients rather than just those that can afford it? So I think that's one area that I think we really need to think about how we can improve access to support services. And then also the palliative care, the name palliative care, I think it really still is so misunderstood by patients. I still see a lot of people, every time you mention those terms, they just think that it means it's for when I'm about to die, I'm in the last hours of life, and trying to how do we change that? I think it is changing. But how do we improve awareness of how palliative care can be really helpful, and probably more helpful if people are referred a lot earlier in their breast cancer journey as such, rather than right at the end. And I think we were seeing that patients weren't accessing palliative care because most of them weren't being offered it. So how do we get our clinicians to think about it earlier and refer earlier?
Yeah, such important points. And I think when we think about the training of the next generation of oncologists and nurses and advanced practice providers, I think more dedicated time within training programs where we are focusing on symptom management and supportive care. I think it's very much lacking right now. So this is something that we hope to absolutely improve on. We're also quite often hearing from primary care clinicians who also feel that they have inadequate training in the care of patients with advanced cancer. So that is another area that there is an opportunity for additional education. Eva and Fatma, in terms of European resources for support services, do either of you want to comment on that?
Do you, just wanted to say one thing about exactly the primary care and the, let's say, the non-oncologists. I think that supportive, what we call supportive care, so everything that is, let's call it symptom and side effect control is probably provides better understanding of what we call supportive care. I think it has to be spread out, and everybody should be at ease to provide this care for cancer patients. At least where I come from, it's very frequent that once somebody has a diagnosis of cancer, the primary care physician says, oh, you have to deal with your oncologist only. I don't care, I will not take care of you anymore because you have cancer. And that is really unfeasible. There are not enough oncologists in the world to take care of all the cancer patients. So involving more the primary care physicians and the other non-cancer specialists is fundamental. And there are a lot of misconceptions also about advanced cancer among those non-cancer specialists. I think one of the situations where we saw that very roughly, we have seen that was during the COVID pandemic, and how the cancer patients, even those who did not have metastasis, were put down in priority to be treated for COVID. So there's still, when we speak about misconceptions and stigma, don't think it's only on the general public. There's a lot of it within the healthcare profession as well, and I think we need to fight against that as well. But we have two questions. So.
Yes, so if we can start there.
Okay, yeah, thank you very much. My name is Ronsi Chidebe. I'm the Executive Director of Project Pink Blue in Nigeria. I'm a patient advocate myself. I just wanted to say firstly that I'm actually part of the authors for the Decade Report, and I would really say that after reading the sessions that I was not part of, I could really say that this is truly a global report. And I hope that this report will make the desired change that we want. However, after reading the report, I realized that we had so many recommendations as well as the gaps, which I think it's really, really important. However, from Nigerian perspective, and I think from many low and middle income perspective, we are no longer battling with social determinant of health. We're now battling with what I call political determinant of health. Because it's usually people who are in power that determines how you have access to care or not. In fact, we have situations where my president, for instance, actually traveled to London and France for his health care. So in those cases, would he care for patients with metastatic breast cancer when he actually have to fly to Paris to get the best care? So I don't know if you all have answers to this, but it's just what can we do to get these conversations more beyond the patient advocate and beyond the scientists in this room as well, to ensure that we get it to the policymakers to continue to bring the change that we need. Just to close, the last biggest problem right now in Nigeria is that the pharmaceutical companies are exiting the country. Pharma companies are exiting, so we're losing patient access programs. How can we get policymakers more to be engaged, to see this report, to utilize the recommendations in this report? These are really my concern, and I'm really willing to learn more. Thank you.
Thank you so much for your important points. And could you just elaborate a little bit why this exit is happening? Is it due to political conditions?
Oh, thank you very much. It's really multiple, and from Project Pink Blue point of view, we hosted a session asking the politicians, bringing the pharma companies, bringing different actors to discuss what exactly is happening. Three major points of what is happening is that we had huge exchange problem, exchange in the sense that the dollar is increasing. So $1 in Nigeria, it's like 1,500 naira. So what that means is that the pharma companies don't produce in Nigeria, they have to import. So it becomes so difficult that they have to give so many medications to the hospitals, and the hospitals are not paying back because of out-of-pocket expenditure. That's number one. Number two, there are so many taxations that really occurs from the government, import duties and all the rest. We're grateful to Nigerian government, honestly. We did an advocacy in 2014, and in 2015, the government removed some of those taxes. The third part is also the issues that has to do with the environment in terms of storage and so many other issues. There are zero clinical trials happening in those countries.
Yeah. Thank you so much. Thank you so much. I think very complex issues, and I think the ABC Global Alliance has really done a wonderful job to also address simultaneously the unique needs that are faced in the LMIC. I think it's not something that obviously we can find a solution for at this moment, but Fatma, I think next steps would be further dissecting kind of these different socio-political patterns that are happening.
I think it is, the only thing I can say to Ransi now is that one fundamental group of stakeholders that we are, I would say there are two stakeholders that we are having trouble reaching, and that we need everybody's help, because I think it has to be all our responsibility, not just of one or two people, is the politicians, the decision makers. They need to know the reality and the impact of their decisions. And also the regulators, which I think are also very siloed and take their own decisions, not just the big regulators, but the national regulators as well. And they need to be more involved in these discussions before taking the decisions. So I think it is up to every one of us to reach out to those people and to make noise. And I know that you are good at making noise.
Yes.
So.
Yeah. Thank you. Next question.
Hello, my name is Heather Jose. I was diagnosed with metastatic breast cancer in 1998 at the age of 26. And I just, as somebody who is here as a patient advocate and is trying to meet the needs of my community, I have been I love to talk about the relationship, the relationship that I've had with my oncologist over the years, and even the impact that she has made on me. Her words started me along on the hope right at the very beginning. My first oncologist had told me literally to get my affairs in order. So I just wanted you to talk a little bit more, or if you can just share, how can we as patient advocates, but also providers, how can we partner together to talk about how much the relationship between the people really matter, and what are some things that you feel that patient advocates can do to impact that?
Thank you so much, and thank you for that wonderful question. I think it is one of the most important relationships, the relationship between an oncologist and patient. And there's a whole science of communication evolving in terms of how can we communicate better so that both parties feel heard and that true shared decision-making is taking place. I'm going to turn it over to Eva from her expertise on this important question.
Thank you. Well, this is the whole part about communication, right? And how much has to come from the physician or the nurse, and how much has to come from patients. And I think we have to educate both sides and just make very clear, especially in the metastatic setting, that it's all about priorities in life of patients, and they change from progression to progression. They change. What is important now is maybe not important after the next progression. So what I expect from my treatments is changing. And I think this is key of all communication in MBC, that physicians understand where the patients stand. And only patients can communicate, but physicians can ask, where do you stand now? What do you expect from your next treatment? What is important in your life? And I think each discussion that starts like that is a good discussion.
I appreciate that. So like the hierarchy is very true, right? If you're worried about progression, you're at survival. But when you've been coasting along unstable for a while, then you can think about quality of life and all of those other issues. So,
Yes.
thank you.
I think I'd just quickly add just to that point also that that we need a lot more focus on communication training for our oncologists. So as they're coming through their training and learning about oncology, there should be a big emphasis on communication training because it's such an important skill.
And building trust, I think, like any good relationship, trust needs to be built over time. So you said, what can you do as a patient advocate? I think as you're interacting with patients newly diagnosed, kind of emphasizing that, one, it can take time to build that trust, but if something feels uncomfortable, for them to also know that it's okay to look at another relationship that might be better for them. Thank you so much to our wonderful panel and to our wonderful audience for joining today. The work will continue. A lot has to be done, and I'm very grateful to the ABC Global Alliance and all the leadership from Dr. Cardosa in leading this charge. Thank you so much.
Thank you.